I think research is very important. I always say that you do good clinical work, you do good care, if you do also some research. Otherwise, it's just repeating what other people tell you to do, but it's not the same thing. It's not easy, because in general, at least in Italy, we are not paid to do research. Our time is considered for care, and if you want to do research, basically you do it on your own time. You write papers during the evenings, on the weekends, but I think it's rewarding. So if you want to do research, one first thing you have to have is a question. You have a question, you don't have an answer for the question, and you try and give an answer to that question. And so the question should be meaningful, of course, for advancing one area. Can also be a small thing. I've seen last week a paper published in JAMA, Neurology, by an American group, Elizabeth Loader. She just evaluated the possibility to induce serotonergic syndrome in patients using antidepressant and triptans. So it was a very simple question, well-done study, large number of subjects, and the answer was no. Patient prescribed triptans are not more at risk of serotonin syndrome, so it was worth it. Simple question, simple answer, and so the question has to be meaningful. It can be also a small aspect, but it has to be meaningful. It should be preceded by analysis of the literature, because if you can find the answer to your question in the literature, it is useless to just predispose a study, invest your time, invest your money. And of course, whenever you have a good question, you have to associate it to an appropriate study design. And this is a slide showing you the names of the possible study designs. You can have descriptive studies, and basically they are a community survey, or you can have analytic studies that can be experimental, and so you have randomized control clinical trial and non-randomized clinical trials, or you have non-experimental, so you can have a cohort study, cross-sectional, case control, or even other types of study. You have to consider and be aware of the possible bias and try to avoid them. The bias is any influence which acts to confuse your data, which acts to make the observer, the results, non-representative of the true effect of, for instance, therapy. An example, you give treatment A to patients who are generally more healthy than patient receiving treatment B. That's a bias. Okay, so you have to be careful and avoid the bias. Another thing you have to be aware of is variability. Because high variability makes it more difficult to discern the treatment difference between two or more groups. And so some possible sources of variability, I've listed them. Some are related to the measurement. You have to use an appropriate instrument. It has to be reliable. Some variability may be related to the observer, so the importance to train the observers, if it is a multicentric study, to train them all in the same way. It may be related to biological factors, so difference within individuals or between individuals. And consider that you might not be able to control for all sources of variability. So whenever you show that you have done the best you could in that condition, that would be acceptable. So when we talk about bias and variability, in general, the clinical trial are the design that is considered the gold standard in clinical research because they offer the best possibility to reduce the bias and to reduce the variability. Consider that in general we think that bias affects accuracy, that is the measure of systematic errors, while variability affects the precision, which is the measure of random errors. Fundamental principle to try and avoid bias and to try and avoid variability as best as you can is that groups must be alike. Alike does not mean identical. There is no way we can find two groups that are identical. In the snowflakes, you can't find two that are like the same. They can be similar, but they are not identical. And in general, when we talk about comparable treatment groups, we consider alike on the average. So as a group, not alike the individual people. Why is this important? It's important because if there is an imbalance in a group, then the difference that you observe may be linked to that imbalance and not to the real effect of your intervention. So that is really important. And I've given there an example. If, for instance, you give a drug X and you evaluate this drug X versus placebo, and for instance, you know that female sex is a risk factor for migraine, and you have imbalanced groups, that alone will drive your result, but your result will not reflect what it is actually the reality. So how can we, what's the best way to ensure comparability of the study? The best way is randomization. Randomization is the best way we have to balance all the factors, and if randomization works, you will have groups that will be similar in all aspects except for the treatment or the treatments that have been administered. And so the simple way to do randomization is that you enroll patient in a study and you randomly assign one patient to one group and one patient to the other group. That is very simple, but probably is not the best way to do, because in the end you will not end up with the comparable groups. So one thing that it is usually suggested to do is that instead of doing this like tossing a coin, group A, group B, it is suggested that we use, it's lunchtime, I don't want to bore you, so I'm going, if I'm going too fast, just stop me and I will go back to the previous slides. So probably the best way is using block. If you use a block, like a block size of 4, for the random assignments, this blocking, so you will have like a AABB, and then ABAB, and then ABA. You see, it's very simple, and you can find on the web the application that give you a list of randomization also with blocks, and in this way, it's the best probably way to ensure balance after every 4th assignment. Another thing that it is important is stratification, because you need to create strata. An example is what I told you before about, for instance, medication overuse. You wanted to do a trial on chronic migraine. You know that chronic migraine patients, they have medication overuse in 50 to 70% of the cases, depends on whether it is a European study or a US study. But what do you do with patient? You just want a chronic migraine without medication overuse? You will select a population that is not representative of the general population. Do you only want the medication overuse? So one thing to do is that I want like not more than 40% of patient not overusing and the other 60% patient overusing, and then I stratify my 2 groups according to overusing and not overusing. That again will ensure you to end up with comparable groups. There are some alternative, because sometimes you cannot randomize. For instance, our Como Esta studies, we have published, I don't know how many papers, more than 10, probably more than 15, and we didn't do any randomization. It was not possible, because in one group we were going to use a diary that was being created, and we had only 3 years, so if we had to wait for having the diary prepared and then randomize the patient to one group and to the other, we would have never finished within the 3 years, and the European community would have taken the money away from us, and we wouldn't have had the 15 papers or what we have. So sometimes you cannot do that, and so there are possible alternatives. They are not optimal, I put it in red, but they are there. So historical controls, that is acceptable, non-randomized concurrent controls, different treatment per physician, or systematic alternation of treatment. As I say, they're not the best, but you can use it, and then you have to be aware that you might have bias. So probably you cannot access to the very top publications, but as long as you put this problem in the limitation of your paper, it can be accepted. Blinding. Blinding is another way to reduce bias, And blinding means that you mask the identity of the assigned intervention, and the main goal is to avoid potential bias caused by the conscious, and sometimes be aware of the subconscious factors that are also very dangerous. And you can have a single blind, only the patient is blinded. Double blind, the patient and the assessing investigator, they are both blinded. And you can also have the triple blind when also, like a monitor or a statistician, all the people having to do something with the study, they are all blind. How to blind? The simplest way is to use a placebo. So if you're evaluating a drug, a pill of the same size, of the same color, of the same shape as the treatment. More difficult is if you are evaluating, for instance, neuromodulation, because in that case you use sham operation for stimulation, or if it is an invasive procedure, you have to use sham operation. There are ethical for a sham operation, there are ethical concerns, but sometimes you have to do it, because, for instance, for the closure of the PFO, it seems from the first open label trials, it seemed that it was effective as a preventive treatment for migraine. And then when they performed the first double-blind study with a placebo, with a sham operation, it turned out that it was not effective. So basically, you sacrificed a small group of patients who underwent a sham operation, but you saved a lot of useless intervention to a very large number of patients. So it is the best trade-off between ethical consideration on one side and the result that you can have on the other side. Sham device, we will talk about this in another slides. And so I told you about the conscious and unconscious effects. Why should the patient be blinded? There are several reasons. I listed here the most important. Patients who know that they are receiving an active treatment, they might report more placebo effect or less side effects. No. Patients not on new or experimental treatment may be more or less likely to drop out of the study, or they may have some preconceived notion about the benefits of a therapy. Or in some cases, some patients, that is not so unusual. Sometimes patients, they feel bad. You give them a drug, is not working, and they feel bad. So maybe they might tell you, okay, you gave me the active drug, I want to tell you that it's working. So it's another way to alter the results. So it is important because, for instance, I showed you this paper. It was published 4 decades ago on JAMA, and you can have, in some study, you can have a very high placebo effect if you are not very careful about the blinding, because in this case they were studying some drugs against pruritus, and it turned out that placebo was more effective, was less effective than nothing, but it was more effective than one of the 2 active treatments. So you have to be very careful, because a very high, we have a problem with migraine because we have a high placebo effect, so we have to be very careful not to bring it higher, otherwise we lose credibility. And also it's important that investigator is blinded. Why? Because probably the treating physician and the person who's assessing the outcome, they might be the same person. So you want this person to be as objective as possible. There might be unconscious bias. I have this hypothesis. I would like to have this hypothesis to prove it true, and that is not the way to do. Also, it might influence also the decision about concomitant or compensatory treatment. I know that I'm giving placebo to a patient who has very bad migraine attacks, so I might be more prone to say, okay, you wait just 1 hour, then take this drug. So that will alter your trial. So you have to be careful on that. But can blinding always be done? Sometimes it's very difficult. I give you another example. I want, for instance, compare monoclonal antibody with the topiramate. You say, yeah, that's easy. Of course, you are forced to give to both groups pills and injection, otherwise it's not blinded. but how can you cover the side effects of topiramate? You don't need to be a doctor to realize that in one group there will be topiramate, in the other one. So some people, they suggest an active placebo. So you put a drug that makes you drowsy. So you don't realize that you are taking topiramate, but that will anyway alter the result. So sometimes really is not possible, especially in the comparative trials. But we have nonetheless tried to do the best of what we can do. So the general study design in general, they are parallel group, dose ranging, crossover, and factorial designs. I'm giving you some examples. This is a parallel group design. You see randomization, 4 arms, treatment A, treatment B, treatment C, and the control. This is a dose ranging. So you have randomization to control, placebo, low dose, medium dose, and high dose. This is a crossover design. The crossover design, you have randomization. One group receives treatment A for a period, then there is a washout, and then treatment B. So each patient is the control of himself or herself, and the opposite is for the other arm. Treatment B first, washout, and then treatment A. Factorial design. Factorial designs is when you use multiple intervention, not only one drug, but you use, for instance, like botulinum toxin and physical therapy for the treatment of cervical dystonia. It's an example. So you have randomization, you have intervention A plus B, A and control, B and control, and then you have control and control. This is something that, for instance, Maria Teresa, we miss in the medication overuse. We don't have a trial comparing detox plus preventive medication, only detox, no preventive medication, only preventive medication, no detox, and none. That is something we don't have in the literature. We should try and do that, but we have already done a lot on medication overuse headache, so I hope someone will do something similar. And then we have the crossover designs. Crossover designs, they have advantages because you need less patients. They might last less, but in the case of migraine, it really is a problem because we know that migraine attacks, the frequency, it fluctuates. So you can use this design when you are sure that during the washout period you recover the baseline condition, because you have a baseline treatment. But I don't know how sure we can be to recover the baseline position during the washout, and then how long must it last. So in the clinical trial guidelines, we did not recommend the crossover designs. Factorial designs, they can be used to evaluate two different interventions compared to a control in a single experiment. So I'm showing this because we might need to use this design in the future if we want to try and combine maybe monoclonal antibody with botulinum toxin in patients with chronic migraine not responding perfectly or sufficiently to one of them. And it is important because basically they tell you the role, the size, the entity of the interaction between the two treatments. Do they interact positively? Do they interact negatively? Is there an increase in tolerability, worsening in the safety? So they can also be important. Randomized clinical trial, of course, they are the best way, as I say, to do research whenever you can do that. It is important to identify the primary outcome measures, and these are the guidelines that we just published in January for chronic migraine. We are preparing now the guidelines for acute treatment of migraine, not chronic migraine. We are making them all new. And so you definitely need to build your study on the primary outcome measure, but it is also important to consider other secondary outcome measures because maybe they will turn out to be more clinically meaningful than the primary outcome measure. And it is, of course, important to prefer objective measures, but we should never forget about the measure that may be relevant for the patients, because this is what they are called PROs, patient-reported outcomes. I think they are very, especially in the field of migraine, they are very, very important. Then there are the cohort studies. court study, they evaluate the exposure to a factor, to a treatment, to whatever it is, not randomly assigned, but that is anyway assessed. The sample selection and the analysis of the population can minimize the confounding variables. Of course, in this case, you need a sufficient number of subjects and a sufficient number of events. In the case of the study I was telling you about, published by Elizabeth Loader, triptans and serotonin syndrome, she had to evaluate like 3,000 patients in order to collect a significant number of serotonin syndrome. Otherwise, you won't have the answer. You can have a prospective cohort, a retrospective cohort. You can also study multiple outcomes. There is no control over the risk factors or insufficient numbers. Cross-sectional studies, all variables are measured at the same time. It's like really a cross cut through the population. It's valuable for providing descriptive information about prevalence, but there is a weak evidence for the causality of one factor as reported to one specific condition. Case control. The subjects are identified as cases based on the outcome status. It is important to identify comparable controls, and that might be challenging. You have to retrospectively evaluate the prior exposure. So it really is a big challenge to, in the end, to be able to account for all the difference between the cases and the control in order to explain the relationship between the exposure to a certain condition and the status of case or control. I'm moving through the final part of the speech because what's the importance of research in headache? We can do research trying to find answers to questions regarding diagnosis, pathophysiology. We know a lot about pathophysiology, but there is a lot that we really need to know. We can do research about treatment. And basically, if I have to nail down the main issues in the pathophysiology of migraine, we need to know more about the machinery of pain. We know a lot, but we don't know everything. And so in this case, there are animal models that can help us. And also we need to know more about the initiation and the origin of pains. I spoke to you before of CGRP. CGRP is the effector branch of the attack of, but we need to know more about where the pain starts and where is the origin of pain. And also in this case, there are neurophysiological investigations. You heard Roberto today, and there are also human models. For instance, nitroglycerin model is a parallel model that you can use in humans, and we have a lot of data also in the animals. And so those are variations that can be used to answer questions about the pathophysiology of pain. This is a table taken from a paper that we published some years ago. There are several types of animal models for migraine. Some of them are very simple, but you see, like in vitro study of arteries, of pieces of arteries. But being simple does not mean that they are not important, because using this model, we got to have the triptans. And the triptans were the first specific drug for migraine. And some others are a little more complicated, but they are easy replicable, and so you don't need any specific, very expensive or sophisticated device to do that. Other areas of interest, in my view, then there are many others, but it's just a suggestion. Something we don't know is the triggers and the neural basis of migraine in terms of mechanism of action. Why a trigger is capable of inducing an attack. It is something we know that there are triggers. We know that some of them work consistently in the same patient, but we don't know why. For instance, menstruation. We know that they can trigger attacks in many women, but do we know why? No, and that it would be something that would be very important to learn more. Difference between triggers and premonitory symptoms. One is inducing and one is the response of the system to the trigger. What's the difference? How do they work? That's an answer that I don't know. Biomarkers. We spoke before about biomarkers. And they would be important for predictive medicine. For instance, if we had biomarkers of the patient who are at risk of becoming chronic, wouldn't that be nice? We don't know which patient will become chronic. You see them, maybe they have 4 attacks per month, and then you don't see them for 2 years, and then they come back, they are chronic. And we didn't have a clue. So for predictive medicine and for preventive medicine, that would be very important. Then another area of interest, in my view, is the aura. The aura and pain. The aura is something that tells you something is going on. So it is a good way to go and study the pain, because most of the patients with aura, not all of them, but most of them, they will develop a migraine attack. So it is another good way to understand. But also learning about the duration of aura. There is a very wide, Michele Viana published a lot on that. There is a very wide variability of duration of aura, also in not only within patient, also between patients, but also within the same patients. The temporal relation with pain is very variable. Some patient the aura ends up, then there is the pain. In some other patient there is an interval between the two. In other patients again there is an overlap. So that is something again that is important. And then there is almost nothing on the treatment of aura. Do you have patients who are treating successfully their aura? I don't. Well, some exception you will hear maybe in the future if Roberto wants to write a paper. I don't know, that's suspense. But anyway, there are no data on the treatment of aura apart those on TMS, single pulse TMS. And another thing that is interesting, and it's becoming more and more interesting also because of the monoclonal antibodies, but not only because of that, the peripheral mechanism. As a neurologist, we always tend to think that everything is happening in the brain. We like things happening in the brain because they are more noble. I don't know, maybe that's what I think, not what you think. But we had to admit that many of the things that happens in the periphery, they are capable of blocking migraine. So the periphery is important too. And besides the monoclonal antibody, they are really big, so they do not cross the blood-brain barrier. And at the beginning we used to say, okay, they do not cross the normal blood-brain barrier, but during a migraine attack there is a disruption of the blood. Now we know that it is not true. During migraine attack there is no disruption of the blood-brain barrier, so this monoclonal antibody will not go into the central nervous system. But we also have the data from we spoke about the cannabinoids. We also have the data, sorry, there is an overlap of the words in the passage from one computer to the other, but anyway, we have the data in the animal model of nitroglycerin. They gave us some enzymes that block the catabolisms of endocannabinoids. So you give these enzymes, you increase the level of endocannabinoids. And they gave us Daniele Piomelli, he works in California, Irvine. He gives 2 types of enzyme, one crossing the blood-brain barrier and the other one not crossing the blood-brain barrier. And with my biologist we say, okay, we are going to try both, but the peripheral one will not work. It worked wonderfully, in the same way as the one that was crossing the blood-brain barrier without side effects, so the rat was not drowsy. So this is something that we should evaluate and know more. Also because in the endothelial cells, you see there are a lot of mediators that might prove to be good targets for treatment in the future. And then one other desiderata for me, it's prevention of migraine chronification. I'm fed up of treating patients who are chronic. I would really like more to treat them before they become chronic. But to do that, we have to be able to understand which of them will become chronic. And so that is another important thing. Medication overuse and medication overuse headache, the waning of the effect of acute drugs, the relapse associated to that. Neuromodulation is something that I showed you the data, but we miss a lot of data on that. And then, of course, drug specific for migraine. This is the last slides. I told you that you need time, you need energy, you need to want to use your private time to do research most of the time, but you also need some practical things. Otherwise, the effort will be too big and you will not accomplish what you want. So one thing is important is to have a dedicated facility for outpatient and for inpatient. That will help you a lot to do good research. A motivated multidisciplinary team. We have now one in Pavia, but we have been struggling a lot in the last 8 to 10 years because they were trying to drag us away from headache. Because if you work in a neurological institute, you will always find someone who will tell you, oh, why do you study headache? Why don't you study stroke or Parkinson? Why do you waste your time? So really you need to have a motivated multidisciplinary team. A headache nurse doing research with you is saving time, saving troubles, and providing a lot of data. It would be good to have a clinical trial center taking care of all the bureaucratical work like approval from the ethic committee, evaluation, all that is very important. It's also important to have a good network of local and international collaboration. That is always very, very good. And of course you need adequate clinical and research training activities. I think, this is the last one. Mondino, you've seen it. The group doing, is not the entire group, the nurses were working, so they couldn't come and have the picture with us. And some other people is missing from the picture. You might recognize Grazia Sanchez here, and Giorgio Sandrini, Marta Lena, Roberto. These are my biologists, and there is one person who is missing, but is never missing, he's always with us, Giuseppe Nappi, Professor Nappi. And is now scientific director emeritus of Mondino Foundation, and here he was receiving his career recognition award last November when we celebrated the centenary of the Mondino Foundation. And this was the last. Thank you.